In the part 3 of the series, we'll be looking at the topic blood. So under blood, we'll be looking at classification. So under classification, some important ones we'll be discussing. That is hematinics. Then there is anticoagulants. Then moving ahead, there is fibrinolytics, antifibrinolytics, and antiplatelet drugs. And also hypolipidemic drugs. So moving to the very first, that is hematinics. Under hematinics is divided into maturation factors, adjuvant hematinics, and iron preparations. So talking about iron is classified into oral iron and also parenteral iron. Oral iron is divided into ferrous group and also the ferric group. Ferrous group, there is gluconate, aminoate, succinate, sulfate, and fumarate. Under ferric, there is ammonium citrate, hydroxy polymaltose, and also there is carbonyl ion and iron calcium complex. Moving ahead to the parenteral ion, there is iron dextrin, iron sorbitol, citric acid, ferrous sucrose, and ferric carboxymaltose. Then moving ahead, under maturation factors, there is vitamin B12, cyanocobalamin, hydroxycobalamin, methylcobalamin. Everything comes under vitamin B12. And then folinic acid. We have folinic acid, levorin, citrovorum factor. Then moving to adjuvant hematinics, you need to know copper comes under this, and also pyridoxine and riboflavin. Moving ahead to anticoagulants, very important. There is parenteral anticoagulants and also oral anticoagulants and in vitro anticoagulants. So moving to in vitro anticoagulants, there is heparin and also sodium compounds, that is edidate, citrate, and oxalate. Then moving to coumarin derivatives, there is bis-hydroxycoumarin. All coumarin products are there. There is bis-hydroxycoumarin, acetylcoumarin, ethyl bis-coumacetate, and warfarin sodium. Very important, we need to know that warfarin sodium comes under coumarin derivatives. And then going to oral anticoagulants. Under oral anticoagulants, there is direct factor XA inhibitor, that is rivaroxaban. And about the oral direct thrombin inhibitor, there is dabigatran xylate. And moving ahead, under parenteral thrombin inhibitors, parenteral anticoagulants, under that indirect thrombin inhibitors, there is heparin, that is nothing but unfractionized, and also LMWH, that's nothing but low molecular weight heparin. So under the low molecular weight heparin, there's all parins, that is dalteparin, natroparin, ardiparin, parnaparin, enoxaparin, fondaparin, and danaparoid. And also talking about direct thrombin inhibitors, there's bivalirudin. All the rudins are here: bivalirudin, argatroban, and lepirudin. So you have two rudins. Then moving ahead, talking about fibrinolytics. Under fibrinolytics, there's important, the mnemonic is STOT. So there's S for streptokinase, tenecteplase, urokinase, altiplase, and retiplase. Then moving on to antifibrinolytics, there's ESEA, that's nothing but epsilon amino caproic acid. And then you have tranexamic acid. Then moving on to antiplatelet drugs or antithrombotic drugs. There's thromboxane synthesis inhibitor, that is it has aspirin. So very important, aspirin comes under thromboxane synthesis inhibitor, which is nothing but under antiplatelet drugs. And then talking about P2Y receptor blocker, there is prasugrel, clopidogrel, and ticlopidine. Then talking about GP antagonists, there is tirofimab, eptifibatide, and abscimab. Then going on to hypolipidemic drugs, there's HMG-CoA reductase inhibitor, which is important. And here you have all the statins. Okay, simvastatin, lovastatin, atorvastatin, pitavastatin, pravastatin, rosustatin. Then moving on to bile acid sequestrants, which is nothing but under hypolipidemic drugs. Under this, there is cholestyramine, cholestyramine. Then moving on to lipoprotein lipase activators, you have benzofibrate, fenofibrate, clofibrate, and gemifibrate. So you have all the fibrates here. So it's nothing but lipoprotein lipase activators. You have all the fibrates. Then moving on to sterol absorption inhibitors, there's ezetimibe. And moving on to lipolysis and triglyceride synthesis inhibitor, there's nicotinic acid. And moving ahead, talking about folic acid. So we have finished some important classifications. So now talking about folic acid, it is nothing but a combination of glutamic acid, para-aminobenzoic acid, and pteridine nucleus. And present in liver, green leafy vegetables, kidney, and fruits. And requirement of folic acid is increased in case of pregnancy, and usually supplements are given. And talking about the pharmacokinetics, dietary folic acid is nothing but in presence of polyglutamates. So after consumption of polyglutamate in the presence of folate conjugates, it is converted to monoglutamate, and this monoglutamate is absorbed, and it is readily absorbed at the proximal jejunum, and then it is reduced to THF. This THF is later combined with the methyl group and forms MTHF. And this MTHF is transported to various tissues. So talking about folic acid, it is mainly present as inactive form. So what is the active form? Active form is nothing but THF, and this active form is required for what? It is required for biosynthesis of amino acids, purine, pyrimidine, choline, and DNA in cell division. Then causes. What are the causes which results to folic acid? Okay, so the deficiency can be due to decrease in diet intake, malabsorption, vitamin C deficiency, hepatic disease, pregnancy, lactation, that is the requirement is more, and the hemolytic anemia is drug induced, that is phenytoin, anti-folates like methotrexate, trimethoprim, and pyrimethamine. Then talking about manifestations, can manifest as megaloblastic anemia, glossitis, diarrhea, gentle weakness, and weight loss. Then talking about folinic acid. Folinic acid is important as it is required for treatment of methotrexate toxicity, and it acts as an adjuvant in methanol poisoning. Then talking about uses of folinic acid, it is used in megaloblastic anemia, used in case of pregnancy, methotrexate toxicity as mentioned earlier here, that is methotrexate toxicity, and also increases anti-cancer effect of fluorouracil. Then talking about the adverse effects, it may result in hypersensitivity reactions. Then moving ahead, we'll be talking about vitamin B12. Vitamin B12, what we need to know is that it is a cobalt containing compound, and it is synthesized by the cholinergic bacteria in meat, liver, egg, fish, and then it contributes to hemopoiesis and maintenance of normal myelin. So all this is about vitamin B12. Then role. So vitamin B12 has coenzymes which help in metabolic pathways. So the coenzyme forms a methyl B12 and DAB12. So what is DAB12? Deoxyadenosine cobalamin, and methyl B12 is methyl cobalamin. So what is the use of these coenzyme forms? So talking about methyl B12, it is used in conversion of homocysteine to methionine. And then talking about DAB12, it is used in conversion of methyl malonyl CoA to succinyl CoA. Then talking about pharmacokinetics of vitamin B12, what happens is vitamin B12 is ingested, and then along with intrinsic factor, which is secreted by the gastric parietal cells. So this is important to know that intrinsic factor is released from gastric parietal cells. So this vitamin B12 and this IF, what happens is it forms vitamin B12 intrinsic factor complex, which binds to a receptor in the terminal ileum, and then it moves on to the blood as vitamin B12 transcobalamin 2, and it is transported to various cells. And in case of excess of vitamin B12, what happens is it goes to the liver, and then it is also excreted in the bile and also goes to the enterohepatic cycling. And manifestations, it manifests as megaloblastic anemia, and megaloblastic anemia can be seen by pallor of the skin and mucous membrane, and also subacute combined degeneration of both posterior There is ataxia and lateral, that's spastic paralysis, columns of spinal cord. Then paresthesia, peripheral neuropathy, confusion, decrease in memory, hallucination, psychosis. And also glossitis, atrophy of tongue and vagina. Then preparations of this preparation of vitamin B12. It is formed as hydroxycobalamin, cyanocobalamin, methylcobalamin. It's already discussed in the classification above. Then talking about the uses of vitamin B12, it is used for pernicious anemia after gastrectomy. Oral methylcobalamin is used in case of diabetic neuropathies, and also in tobacco, amblyopia, hydroxycobalamin injection is used, and here it binds to cyanide. And erythropoietin, talking about erythropoietin, it is produced by peritubular cells of the kidney in response to hypoxia. And then what it does is it stimulates. Why we need erythropoietin? It stimulates erythropoiesis and acts as erythropoietin stem cell in bone marrow. Acts on erythropoietin stem cells on bone marrow and stimulates erythropoiesis. Then commercial preparation of erythropoietin is epoietin alpha and darbepoetin alpha. Then use of erythropoietin is used in anemia with renal failure, anti-cancer drugs, zidovudine induced anemia, especially in HIV patients. And talking about adverse effects of erythropoietin, it increases BP, that is blood pressure, hematocrit and thromboembolic complications. Also allergic reactions, these are all adverse effects. Allergic reactions and flu-like symptoms. So flu-like symptoms are nothing but nausea, vomiting and tachycardia, and can occur with epoietin. And talking about LMWH, that's nothing but low molecular weight heparin. We have all the parents, that is dalteparin, raviparin, tinzaparin, enoxaparin, rdaparin, and few other drugs are also mentioned in the classification above. And moving ahead, it is obtained. How is LMWH obtained? It is obtained by fractionalization of standard heparin, and also what happens is it inactivates factor XA, that is nothing but the 10A through antithrombin, and cannot bind to thrombin and antithrombin simultaneously. So and it has less effect on APTT as compared to UFH. And LMWH monitoring of APTT is mainly done in case of chronic renal failure, and protamine sulfate does not completely reverse LMWH. These are some bulletin points that you need to know related to LMWH. And then talking about the advantages, why do we use LMWH? So it increases bioavailability and also the T-half. And APTT monitoring is not usually required, but as mentioned earlier, it can be used in case of renal. It can be used in case of chronic renal failure. And then moving ahead, it decreases thrombocytopenia and also osteoporosis. Then just a quick view of the coagulation cascade. So in the coagulation cascade, there's intrinsic system and extrinsic system. Intrinsic system, there's 11. So you need to know these numbers, that is 11, 9 and 10. So from 11 it dips to 9 and then it increases to 10. Okay. So what happens is you have 11 to 11A and then 9 to 9A and then 10 to 10A, and then 10A helps in conversion of prothrombin to thrombin. Okay. So this 12A helps in conversion of 11 to 11A. This 11A converts 9 to 9A, and this 10 to 10A is converted with presence of 9A. Okay. So that's how the intrinsic factor starts. So here talking about the extrinsic system, it's nothing but addition of 7A directly in this step. Okay. And then moving ahead, this 10A, it contributes to formation of thrombin from prothrombin. And this thrombin, what happens is thrombin is helped in conversion of fibrinogen to fibrin. And then this fibrin is formed stable in presence of 13A. So what is the role of LMWH? LMWH is nothing but it inhibits this step of the coagulation cascade. Then moving ahead, we have warfarin. So what is warfarin? Warfarin is nothing but synthetic anticoagulant. This is very important to know. Warfarin is a synthetic anticoagulant, and it is active in vivo and given orally, and also it inhibits synthesis of vitamin K dependent clotting factors, that is 2, 7, 9 and 10, and delayed onset and long duration of action, that is one of the property, and it is monitored by measuring INR. An overdose is treated with fresh frozen plasma and vitamin K. And this warfarin, what happens is it crosses placental barrier and has a teratogenic potential, and it is not expensive. Adverse effects of oral anticoagulants in general, what happens is it leads to bleeding, teratogenic, that is talking about drugs, that's warfarin. It has CNS manifestations, nasal hypoplasia, fetal hemorrhage, abortion, and IUD, intrauterine death, and skin necrosis and others such as diarrhea, alopecia, urticaria, dermatitis, and anorexia. So talking about the mechanism of action of warfarin, very important. So what happens is vitamin K, it is not able to be converted to the active form. So a vitamin K formation requires the presence of epoxide reductase. So this epoxide reductase is inhibited by the presence of warfarin. So that's what is seen here. And going in detail, I just told you that inactive form is not converted to active form. But going into a bit of detail, you have the facts 2, 7, 9, 10, which is non-functional clotting factors. So they are turned into functional in the presence of vitamin K. So this is where this active form forms a role. So vitamin K, in presence of the process of carboxylation, it forms the functional part, and this functional part contributes to the anticoagulant property. Then moving ahead, there is some drug interactions that we need to know, that is warfarin. Warfarin along with cholestyramine, it decreases the bioavailability, and in presence of barbiturates, carbamazine or rifampicin, it decreases the anticoagulant effect, and in presence of oral anticoagulants, it decreases the anticoagulant effect, and in presence of phenytoin and sulfamides, it decreases bleeding, and in presence of erythromycin and metronidazole, it causes decrease in anticoagulant effect, that is, it decreases the metabolic clearance of warfarin. Moving ahead with tetracycline, it decreases vitamin K production, and cefoperazone and ceftriaxone, it causes severe bleeding and also results in hypoprothrombinemia. And in presence of aspirin and NSAIDs, it decreases anticoagulant effect, and in presence of, then moving ahead with tranexamic acid. Tranexamic acid is nothing but it's a potent antifibrinolytic. So just going ahead, there are so many drugs to memorize. I'll just recap just the name of the drugs: cholestyramine, barbiturate, carbamazine, rifampicin. Oral contraceptives, phenytoin sulfamides. This phenytoin and sulfamides, it increases the bleeding. That should be known. And erythromycin and metronidazole increases the anticoagulant effect. So others, cefotriaxone, ceftriaxone and cefoperoxide, severe bleeding, hypoprothrombinemia. So just read this over and over again, then it will be easier for you. Then moving on to tranexamic acid. Tranexamic acid is a potent antifibrinolytic. It is used in excessive bleeding and fibrinolytic overdose, dental extraction in hemophiliacs and menorrhagia. And side effects, it causes nausea. All this is about tranexamic acid. Nausea, vomiting, diarrhea and headache. So this diarrhea, it forms a major role. It's very common throughout most of the drugs. Then moving on to clopidogrel. Clopidogrel is a P2Y receptor antagonist, and other examples include ticlopidine, clopidogrel, prasugrel, candogrel, ticagrelor, and moving on to uses. Uses, you have general antiplatelets. General antiplatelets, there's acute coronary syndrome, CAD, prosthetic heart diseases, valve thrombosis, thromboembolism. Then talking about and also TIA, that is transient ischemic attack, and also PAD, that's peripheral artery disease. Moving on to mechanism of action of clopidogrel. Clopidogrel, what happens is To make it simple, platelets, it releases ADH. So what happens is this ADH acts on receptor A. Assume it acts on receptor A. So this receptor A activates receptor B, and this helps in formation of fibrinogen along with receptor on platelets, the GP receptor on platelets, and this leads to platelet aggregation. So going back, platelets, it releases ADH, it acts on P2Y receptor, and this stimulates the GP receptor, and then it acts, then helps in fibrinogen binding to the GP receptor on platelets, and finally it contributes to the platelet aggregation. Then moving ahead to the last topic, that is plasma volume expanders. Plasma volume expanders, it's a temporary maintenance of blood volume in emergencies. So colloidal solutions are used, that is nothing but albumin, dextran, polyvinyl, pyrrolidone, and hetastarch, degraded gelatin polymers. So talking about the properties, they have the same, these are the criteria that needs to be met in case of plasma volume expanders. That is, it has the same property as that of plasma, that is same pH, oncotic pressure and viscosity. Then also it is retained in the circulation and non-progressive and non-antigenic. And it is also stable and does not interfere with any other blood grouping. Uses, where is this plasma volume expanders used? It is used in burns and also hemorrhage and trauma, that is to maintain the blood volume. And where is it contraindicated? It is contraindicated in presence of in anemia, bleeding disorders, congestive heart failure, renal failure, hepatic failure. Then adverse effects. Adverse effects, it is of albumin, mainly hypersensitivity, circulation overload, Rolex formation, and it interferes with Rolex formation. That is, this is about dextran, and dextran is of two types, that's 40 and 60. Okay, then moving ahead, it interferes with blood grouping, cross matching, also hypersensitivity, fever, urticaria, joint pain, hypotension, bronchospasm, and anaphylactic reaction. Then talking about hetastarch, it has flu-like symptoms, and flu-like symptoms we have already mentioned earlier in one of the drugs, that is, it headache, fever, myalgia, itching, and also urticaria and anaphylactic reactions are also seen. And degraded gelatin polymer are also this polyvinyl. Degraded gelatin polymer. There is flushing, itching, urticaria, bronchospasm, and hypotension. Then last, you have the polyvinyl pyrrolidone. It interferes with the blood grouping and cross matching of the blood, and it along with insulin and penicillin, in blood, it decreases its effect. Just recapping of what we have covered and what we need to know. I'll just be briefing quickly. So moving front, still going. Yeah. So blood, there's mainly classifications, hematinics. Then there is anticoagulants which need to be done. Then there's heparin, LMWH important. Moving ahead, there is fibrinolytics. All these drugs are very important even in practice. Then also antifibrinolytics. Then antiplatelet drugs. Moving hypolipidemic drugs. Then we have already also spoken about folic acid. It's nothing but combination of these three. Moving ahead, we have seen that active form is THF, that is required for biosynthesis of these products. And causes we have seen, that is mainly decrease in diet intake. And then there is folinic acid, treating methotrexate. Uses simple, in pregnancy, megaloblastic anemia, toxicity, that is methotrexate toxicity. Moving ahead, vitamin B12. Vitamin B12, what we need to know is it's a cobalt containing product, and it has these coenzymes, that is methyl B12 and DAP12. Methyl D12 helps in conversion of this, and DAP12 to this. Then moving ahead to pharmacokinetics, there is the vitamin B12 combines with IF, forms this complex. It is then it moves to terminal ileum, binds to receptors, and then in blood it appears as this, and then it's transported to various cells. And excess, what happens is excreted in the bile and undergoes enterohepatic cycling. Then you need to know the manifestations. There's spastic paralysis and ataxia, paresthesia. Then preparations, vitamin B12, all these cobalamin compounds. Uses pernicious anemia, tobacco amblyopia. Then erythropoietin, produced by peritubular interstitial cells of the kidney in response to hypoxia, important. Then use anemia, anti-cancer drugs, zidovudine-induced anemia in HIV patients. Then adverse effects, same like flu-like symptoms, allergic reactions, they are common and in most anticoagulants, and also increases the BP, hematocrit. Then LMWH, you have all the parents, that is easy. And then talking about the advantages of LMWH, increase in bioavailability and TR, very important, and decreases thrombocytopenia. Then coagulation cascade is important. Memorize these numbers, that is 11, 9, 10, and here from 7, 10, and then it moves on. Then LMWH, it inhibits this reaction step, and conversion of prothrombin to thrombin, thrombin to fibrin. Thrombin helps in formation of fibrin, and fibrin is to fibrin stable. Then moving on to warfarin, it's important to know that it's synthetic anticoagulant and it inhibits synthesis of vitamin K. And talking about adverse effects of anticoagulant oral anticoagulants in general, bleeding, teratogenic. Then moving on to the mechanism of action, inactive vitamin K is not produced because of inhibition of epoxide reductase. And this vitamin K, it plays a role in formation of functional factors 2, 7, 9 and 10. Then drug interaction of warfarin, there are a lot of drugs. So just rewind this, or you can just read this over and over again. That is cholestyramine, phenytoin, sulfamides, tetracycline, aspirin, NSAIDs, just to name a few. Then moving ahead with tranexamic acid. It is a potent antifibrinolytic used in case of excessive bleeding, side effects, vomiting, nausea. Clopidogrel is nothing but P2Y receptor antagonist, and other examples include all these. Ticlopidine, clopidogrel, and uses of this clopidogrel, it is used in acute coronary syndrome, CAD, and also in prosthetic heart valve. So under this, valve thrombosis, thromboembolism, very important. So it's used in heart related. Okay, so this is nothing but clopidogrel. Then mechanism action is simple. This platelets, it forms ADH, it acts on P2Y receptor, and then it activates GP receptor, and then it helps in binding of fibrinogen with the GP receptor on platelets, and finally it forms the platelet aggregation. Then talking about plasma volume expanders, it is nothing but temporary maintenance of blood volume in emergencies, and colloidal solutions such as albumin, dextran are used, and properties, it has the same properties as that of plasma in terms of pH, oncotic pressure, viscosity, and it is retained in the blood and it's stable and does not interfere with blood grouping. Uses of plasma volume expanders, mainly burns, hemorrhage, trauma, contraindicated in anemia, CHF, renal failure, and adverse effects, mainly just telling in general, hypersensitivity, circulation overload, interferes dextran, Rolex formation, and then also hypersensitivity, fever, urticaria, joint pain, hypertension, bronchospasm, and hetastarch, flu-like symptoms as mentioned earlier, headache, fever, and then degraded gelatin polymer. It results in flushing, itching, urticaria, bronchospasm, hypertension. Then polyvinyl pyrrolate, it interferes with the blood grouping and cross-matching of blood, and along with insulin or penicillin, in blood it decreases the effect. So that's it. We have covered part 3 of blood, and I believe this is the longest of the part till now. And in case you like the video and you want to show support, please subscribe, and to continue making such good educational content. And part 4 will be released soon. So thank you.